Okay. Assalamu alaikum everyone. My name is Hala Sammour. I'm a fourth year medical student, and today, inshallah, I'll be presenting you the second part of the MSI crash course. We'll be talking about muscle and connective tissue disorders. So, this crash course is going to cover 9 lectures in total. We'll be talking about muscle physiology, clinical investigations of MSK diseases, genetics of muscle disorders, muscular dystrophies, path of muscle disorders, inflammatory myopathy, fibromyalgia, systemic presentation of MSK diseases, and finally, we'll cover your first immunolecture. So since this presentation is recorded, I have put my contact info over here. If you guys have any question regarding this session or anything else, just feel free to contact me. Inshallah, I'll be more than glad. I'll be really happy to help you out, inshallah. Okay, starting off with the skeletal muscle physiology, let's start basic. First of all, let's understand the structure of the muscle. By now, I think most of us know that the muscle is a fancy cell that likes fancy names. So, for the cell membrane of the muscle cell, we say the sarcolemma. The cytoplasm is called the sarcoplasm. The endoplasmic reticulum is called the sarcoplasmic reticulum. Now, what about the contractile structure? So, the muscle cell is made up of myofibrils. Those include the actin, which is the thin filament. This actin, as you can see it over here, it's the thin filament of the contractile structure. It's composed of tropomyosin and troponin. Myosin on the other side is the thick filament, as you can see over here. Now, this myosin is made up of the myosin tail, the hinge region, and the myosin heads. Okay, so this is the structure of the muscle cell. Just to orient you out, so here we have the sarcolemma or the cell membrane of the muscle cell. What's under that is the complex structure of the muscle cell, as you can see, and what's above that is the extracellular matrix. Okay, so here, as you can see, is the thin filament or the actin that we talked about in a bit, and this is the thick filament or the myosin, and then these are joined together by this protein called the titin. I don't want you to overwhelm yourself with the complexity of this cell. I just want you to see over here this protein called dystrophin. So what I want you to understand is that the dystrophin is a protein that is located underneath the sarcolemma. And why is it important? This protein is going to transfer the force from the contractile system over here. So this is the contractile system. It will transfer the force from the contractile system and give it to the extracellular matrix. So this is what's going to allow the contraction of the muscle. Now, there are many diseases where this protein is disrupted, and we're going to go through them in your clinical lectures. Okay, so I just want you to note that this lecture was pretty dense and it had a lot of information from your first year slides, which is not required from you in this year. I think the doctor just included everything for the sake of completion. So what I did is that I did add everything the doctor has in your slides. However, I'm just going to explain or I'm going to focus on what the doctor either highlighted or mentioned as high yield. Okay, and if you guys want to go over the rest of the stuff that are not really high yield, everything is found in the slides. Or yeah, if you have later any questions, you can let me know. So as you can see, this is the muscle and the plate. So here we have, this is the neuron, this is the postsynaptic membrane, and then yeah, so here, this is the motor end plate or the neuromuscular junction. As you can see, here we have the acetylcholine that needs to bind to the postsynaptic receptor. Now, why is this important? Let's understand the Lambert-Eaton disease. So, in order for acetylcholine to be released from the neuron and to be attached to the postsynaptic receptor, voltage-gated calcium channel need to open in order for calcium to enter and this acetylcholine to be released. So what happens in the Lambert-Eaton disease, we have presynaptic voltage-gated calcium channel antibodies. So we no more have this channel over here, so no more calcium influx, so no more acetylcholine release. And by that, we can't have a contraction. Now, an important thing about this disease is that it's an incremental disease. What this means is that you wake up feeling very weak, or the patient wakes up feeling very weak, and then as the day goes on, because of the calcium accumulation, calcium is going to accumulate, وبعدين we are going to have a bit of influx because of the accumulation of calcium. So the patient is going to tell you, after I start exercising or after I start my day by a couple of hours, I see that I'm getting better. And this is unlike myasthenia gravis. What is myasthenia gravis? As we said, the acetylcholine needs to be released from the neuron and to attach to the postsynaptic receptor at the neuromuscular junction. Okay, now in myasthenia gravis, we have postsynaptic acetylcholine receptor antibodies. What this means is that even there is acetylcholine in the motor end plate, however, it's not able to attach to the receptors on the postsynaptic membrane. So postsynaptic acetylcholine receptors, and unlike the Lambert-Eaton, this is a decremental disease, meaning the more you use your muscle, the weaker you feel. So you wake up feeling your strongest, and then at the end of the day, you feel very weak. So the patient is going to tell you, I have muscle weakness at the end of the day, especially if I exercise or if I do any activity. Okay, so just let's go over these steps over here. We said acetylcholine at the neuromuscular junction is needed. So we have sodium entry through the acetylcholine receptor channel, which initiates a muscle action potential. We need a muscle action potential, right? Okay, now this action potential in the T tubules will alter the DHP receptor. This DHP receptor is going to open ryanodine calcium channel release into the sarcoplasm. So after the DHP receptor is altered because of the action potential, we have the ryanodine receptor calcium channels will be open, which is going to allow influx of calcium into the cytoplasm. This influx of calcium is going to bind to troponin, if you remember, the protein that is found on the actin, allowing the actin-myosin binding. So myosin heads is going to execute the power stroke, and the actin filament slides toward the center of the sarcomere. So what's important to know, after the calcium influx into the cytoplasm, because of the ryanodine receptors opening, we are going to have a contraction. Now, why is this important? We have a disease called the malignant hyperthermia. What happens here is that we have a mutated ryanodine receptor. So the ryanodine receptor is mutated and it does not close. It's always open. When this membrane or when this channel is always open, we have uncontrolled calcium release into the cell. And because of this release, the muscle is not able to relax. There is a complete state of contraction because the myosin and the actin are binding together and they're not able to just pull away. This condition is called malignant hyperthermia and it's going to cause muscle rigidity, again, because of the continuous contractions. This is triggered by anesthetics or by stress. Okay, just for the sake of completion, what happens usually is that the calcium ATPase pumps calcium back into the sarcoplasmic reticulum. When calcium is decreased in the cytoplasm, we are going to find the myosin and actin detachment, causing the muscle relaxation. Again, this does not happen in malignant hyperthermia because this channel, the ryanodine channel, is always open, causing calcium influx. Okay, so these are some conditions that your doctor highlighted and again mentioned again in the high yield slide you have at the very end of your presentation. First of all, we have the botulinum toxin. The botulinum toxin, it prevents acetylcholine release from the presynaptic terminal. So remember Lambert-Eaton, we said that again we don't have acetylcholine release because of autoantibodies against the calcium channel. And here they just prevent it in some way. They prevent the acetylcholine release from the presynaptic terminal, causing flaccid paralysis. Next, we have the organophosphates. Those inhibit acetylcholinesterase, so acetylcholine is going to accumulate. What is acetylcholinesterase? Acetylcholinesterase, it is an enzyme that breaks down acetylcholine. Okay, so usually acetylcholine, after it's released and after it binds to the postsynaptic receptor, acetylcholinesterase is going to break it down وخلاص يعني it's going to end the contraction. In organophosphates, they inhibit the acetylcholinesterase, so acetylcholine is going to accumulate, no breaking down of the acetylcholine. This is going to produce a severe cholinergic overstimulation. And this is treated with atropine, which blocks the muscarinic effects. Finally, we have the pancuronium or the curare. I think that's how it's read. Those are competitive antagonists at the postsynaptic acetylcholine receptors. So this mimics myasthenia gravis, but they're not autoantibodies against the receptors. They're just antagonists at the postsynaptic acetylcholine receptors. Again, this causes flaccid paralysis. طيب بصراحة I do not remember these couple of slides in our presentation at all. I'm not sure if they're new ولا they were very low yield that I did not go over them. But what you need to understand is that the action potential is a very يعني clean or like organized process where we have electrolytes coming in, electrolytes coming out, وطبعا in specific amounts. So what this slide wants from you to understand is that in cases of hypokalemia, excuse me, in cases of hypokalemia where the potassium is very low, as you can see here, potassium is very low, we have a state of hyperpolarization. Now, when we have a state of hyperpolarization, this causes the muscle membrane to be less excitable. So when the muscle membrane is less excitable, we cannot have another action potential over here. So this is going to cause muscle weakness or periodic paralysis. What is the trigger? High carbohydrate means. Why? Because insulin is going to drive potassium into the cells. This is a very interesting piece of information, by the way, and if you memorize this so the next years, um, يعني if you ever said this thing in front of doctors, they'll see you as geniuses, by the way. So just for the sake of your knowledge, especially in clinical years, I mean, just know that insulin drives potassium into the cells, causing hypokalemia, causing a state of hyperpolarization, so less contraction. On the other hand, you have the hyperkalemic periodic paralysis. So even hyperkalemia can cause paralysis. Why? Because when we have a lot of positive ions inside the cell, we're going to have a state of depolarization. And when we have a lot of depolarization, no other action potentials can take place, right? So again, this causes periodic paralysis, and this is triggered by potassium ingestion. Okay, so I've put the slides here just for the sake of completion, but it's not really important. This is like typical first year slide. You just need to understand that the power stroke is it's the most important step in the muscle contraction, and it happens after the calcium binds to troponin, allowing the myosin and the actin to bind. Myosin binds strongly to actin and completes the power stroke, and then the actin filament moves. You can just read it. I don't think you'll be getting a question on this. Now, skeletal muscle types. It's important to understand. It's important to understand that we have two types of muscle. We have type 1 and type 2. Type 1 is the slow twitch, and type 2 is the fast twitch, right? Okay. So, yeah, type 1 and type 2. I do not want you to memorize whatever is in this table. What I want you to understand is that type 1 muscles are those muscles that are fatigue resistant. I should have highlighted this over here. This is very important. So they are fatigue resistant. So what is an example for type 1 muscle? It's the paraspinal muscles. Paraspinal muscles, which are the muscles around your spine, those are type 1 muscles, slow twitch muscles. They are fatigue resistant. Usually those muscles, they atrophy with disuse. So when some patients just lie down and they do not move their body, this is how these muscles are going to atrophy. On the other hand, we have type 2 muscles. Type 2 muscles are they're easily fatigued. So we have two types. I just want you to see this as one type and focus on this. So type 2 are usually easily fatigued. Those are the muscles found in your biceps, quadriceps, or whatever muscles used in heavy activities. And those muscles, they usually atrophy with aging or with steroids. Okay, so this is important. Aging, steroids atrophies type 2. Disuse atrophies type 1. Now, for the length tension relationship, it's obvious that there is a specific length and there's a specific length where muscles can produce their maximal force, and this is called the optimal length. So optimal length, it is the length of the sarcomere where the number of cross bridges can form is maximal, creating maximal force generation. On the contrary, we have overstretched and overly shortened sarcomere length, and those are not going to cause the maximal force. They're going to cause decreased force. So an important clinical application is that in congestive heart failure or in dilated heart, like in a failure or with dilated heart, you can imagine how the heart is dilated, so the muscles are overly stretched, right? So in overly stretched muscles, we are not going to have the optimal length produced. This is going to result in decreased contractile force. Talking about the contractile force, we have two types. We have the isotonic contraction and the isometric contraction. So isotonic contraction is the contraction that is used to lift an object, for example. So I want to lift my phone. I just hold my phone and lift it. So I'm producing movement. My muscle is changing the length over here because I'm producing movement, but the tension is constant. Why is the tension constant? Because the weight is constant, right? So I held the weight of my phone and I am moving it around. So isotonic contraction produces movement. It includes walking or doing a bicep curl. The isometric contraction, on the other hand, they generate tension, but there is no length change. So I am increasing my tension. For example, imagine just pulling against the wall. You are generating a lot of tension, but the length of the muscle is not changing because you're not producing movement. An example is holding a heavy object without moving. So these are important. I remember we got a question on the isometric contraction. It just said, what type of contraction is this? And they gave us different types of contraction. So yeah, just keep that in mind. And this is our first checkpoint. Let's just have a quick question to assess our understanding. So the correct temporal sequence for events at the neuromuscular junction is, you can pause the video over here. Okay, so it's at the neuromuscular junction. We have uptake of calcium into the presynaptic terminal. We have release of acetylcholine and then depolarization of the muscle end plate for muscle movement to occur. A 42-year-old man with myasthenia gravis notes increased muscle strength when he is treated with an acetylcholinesterase inhibitor. The basis for his improvement is increased what? So if you do not have acetylcholinesterase, what is going to increase? Levels of acetylcholine at the muscle end plate. Excellent. Okay, now talking about the common MSK investigations. So these are divided mainly into three types. We have the labs, the arthrocentesis, and finally the radiographic imaging. Let's talk about labs first. So these include the acute phase reactants, and we're going to talk about what these are exactly in a bit. Autoantibodies, complement, and L should be here, complement, muscle enzymes like creatine kinase and LDH that indicate myositis or muscle inflammation. We're going to talk about that later. And the HLA-B27 is also important because we have some diseases where this protein is found or detected because of the high WBC count. So what are acute phase reactants? Acute phase reactants are a group of proteins that are produced in the liver in response of inflammation. So I'm having an inflammation of the body, so these acute phase reactants are going to be high, they're going to increase. Those include fibrinogen, haptoglobin, CRP, serum amyloid A, ferritin, and ESR. Hala, I would tell you don't need to memorize all of them, just know the most important. But I remember last year we got an ACQ about the acute phase reactants, and they wanted, I think, 4 or 5. So they're good to know. Now, what drives the acute phase reactants to increase in the body? It's basically interleukin 6. So very important. Interleukin 6 is the mediator that brings the acute phase reactants up. Now let's talk about their types. We have ESR, as we said. ESR, it is the measurement of the distance in millimeters that red blood cells fall within a specified tube over 1 hour. Okay, so I put blood in a tube over here, and you're going to notice that the red blood cell is going to fall or it's going to sediment, right? So this distance over here is the ESR. And how does this work? Because in inflammatory stress, we have increased fibrinogen, which is an acute phase reactant. We talked about that. Increased fibrinogen and proteins. Those proteins are going to react with the RBCs, causing increased weight. So they're going to cause the RBCs to sediment faster. So if the RBCs are sedimenting faster and the distance over here is higher, this shows that there is an inflammation in the body. Okay, the upper limit of normal for a man is equal to the age divided by 2. For a woman, we add 10 to the age and then we divide by 2. Okay, so important conditions where the ESR is going to be elevated. Obviously, any inflammation, as we said, so infection, mainly bacterial infections, connective tissue diseases, polymyalgia, SLE, and vasculitis, for example, in malignancies as well, lymphomas, myelomas, so basically any condition of inflammation in the body. Now, when we have low ESR, this is basically when we have low fibrinogen. So there is no fibrinogen to react to the red blood cell, so low ESR, extreme polycythemia, where we have a decreased number of red blood cells, if you guys remember. Ah, well, لا, you did not take heme yet. Okay, you did not take heme yet. So polycythemia is when we have decreased red blood cells in the body. So decreased red blood cells, we're going to have decreased ESR. Okay, next we have the CRP. A CRP is a more specific acute phase reactant. Again, it's produced by the liver in response to interleukin 6, and this is nowadays used more than the ESR. A normal value is typically less than 5 milligrams per liter. Now, for autoantibodies, important autoantibodies include the rheumatoid factor. We're just going to go over a couple, and I'm pretty sure they're going to be repeated through your lectures. As you like, you want to memorize them from now or just memorize each in their specific lectures. So first of all, we have the rheumatoid factor, which is an autoantibody against the Fc of the IgG. So Fc is a fragment of the antibody, basically. Yeah. So RF is basically positive in rheumatoid arthritis that is very aggressive. So if I have a rheumatoid arthritis patient and the RF was positive, this means that this patient has a very aggressive joint disease and is at risk of developing extra-articular manifestation. So we usually detect the disease activity of rheumatoid arthritis by clinical assessment or CRP, not by RF titer. So RF titer is just it's not as sensitive as other testing. Okay. So as you can see here, it sense. Oh, this is the CCP. Sorry. So another antibody for the rheumatoid arthritis is the anti-CCP. Again, those are antibodies against the arginine. They may be a better predictor of erosive diseases than rheumatoid factor, but do not correlate with extra-articular disease. So if I want to assess a patient for rheumatoid arthritis, I start with anti-CCP. If I want to know how aggressive this disease is, I go with the rheumatoid factor. ANA. ANA is an antibody that is usually positive in a lot of immune diseases, but it has to be positive in SLE. It's universally positive in SLE. So it's to the point that I cannot diagnose SLE unless I have a positive ANA. Here we have other antibodies. We have anti-dsDNA or anti-Smith for SLE, anti-histone for drug-induced lupus, anti-Ro, anti-La for Sjogren's syndrome. I don't think you have a lecture on this, so you can memorize it from here. Anti-centromere for Crest syndrome, and this is for the limited cutaneous scleroderma. Anti-SCL, anti-topoisomerase in systemic sclerosis, anti-RMP for mixed connective tissue diseases, and as we said, RF and anti-CCP for rheumatoid arthritis. Now, for complement, I think you guys know by now that the complement is considered an immune, like a part of the immune system. What complement does is that it looks for the disease or for the whatever is happening in the body and it fights it. We have levels of C3 and C4. So this is what's called the complement, right? Okay. So this complement, because it fights diseases or because it fights an inflammation, it's going to decrease in inflammation. So if I measure the complement and I find that it is decreased, this means that there is an active immune complex disease, active immune complex mediated disease in the body, which is using up my complement. Sometimes we have genetically decreased complement, or not genetically, but just because of other diseases. So persistently low total hemolytic complement suggests an inherited deficiency of complement component. We have the arthrocentesis as well, indication suspected septic arthritis. I'm pretty sure you talked about this in the previous crash course, so I'm not going to go to the details of the findings, just understand that there are specific indications of arthrocentesis and that they help us understand the appearance of the fluid, the count of the white blood cells, and like other details that are going to help us better assess the patient. Again, it can also identify gout and pseudo-gout. Radiographic imaging, finally, is also used in diagnosing MSI or MSK diseases. So it can show you these things, the alignment, bone mineralization, classifications, or whatever. So we have X-rays, we have CT or MRI, usually CT and MRI. So your doctor has added the definition of CT and its indications and like a lot of info about CT and MRI in your lecture. They were very basic صراحة, and I thought they're not important. There's no way you'll be asked about them. However, if you guys are, you can go back to the slides just to read about them, but I don't think they're important. So finally, we have DEXA scan, which is part of the radiographic imaging. The DEXA scan is a very important scan for osteoporosis. So osteoporosis, DEXA scan. What it measures are two scores. We have the T score and the Z score. The T score, it compares your bone density to a young, healthy adult. The Z score, it compares to people your same age, sex, and size. What is usually used in our healthcare is the T score. It compares your bone density to a young, healthy adult. And here are the ranges. So normal bone range should be higher than -1. So 0 or +1 is considered a normal bone range. From -1 to -2.5, this is osteopenia. From -2.5 to -4, it shows osteoporosis. And this is our second checkpoint. Let's have a quick assessment. Which inflammatory cytokine is an important mediator that stimulates the production of acute phase reactants? It is interleukin 6. Okay, so finally to the fun part, patho and inflammatory myopathies. What is a myopathy? A myopathy, it is a disease of the muscle fiber itself, and it is further categorized into acquired myopathy and inherited myopathy. Acquired myopathies, or the inflammatory myopathies, they include polymyositis, dermatomyositis, and inclusion body myositis, and we're going to talk about these in detail. The inherited include the muscular dystrophies, like the dystrophinopathies that we talked about. If you guys remember, we said those have the dystrophin protein deficiency or mutated protein. We have congenital dystrophy and metabolic congenital myopathy, like Pom's disease. Let's talk about these in detail, starting off with the inflammatory myopathy. So this group, it is a heterogeneous group of muscle disorders that causes the degeneration of muscles via an inflammatory process. Okay, so we have inflammation of the muscles. The inflammatory infiltrates are mainly mononuclear with T cells, B cells, natural killer cells, and macrophages. So it's important to understand that they are mononuclear. We have three types, as we said: polymyositis, dermatomyositis, and inclusion body myositis. Polymyositis causes symmetrical proximal muscle weakness. So they're all kind of proximal muscle weakness. So polymyositis is symmetrical proximal muscle involvement involving the shoulder and the pelvic girdle muscles affected most severely. What's important is that we have anti-Jo1 antibody in this disease. So polymyositis, anti-Jo1, okay? And we can sometimes see dysphagia and dysphonia, and also myocarditis, interstitial lung disease, or vasculitis. They involve the CD8 positive T cells in the intravesicular and the endomysial region. So this is important. I want you guys to focus on this because this is the only difference that was between your patho and clinical lecture. This was a sentence added in your clinical lecture and it was highlighted, so it's good to know. So again, as we said, polymyositis, symmetrical proximal muscle involvement. It involves the shoulder and pelvic girdle muscles mainly. The antibody is anti-Jo1 positive. We have other diseases that are associated like dysphagia, dysphonia, myocarditis, interstitial lung disease. And how the inflammation occur, it involves CD8 positive T cells in the intravesicular and the endomysial region. So here, as you can see, this picture is from your patho lecture, you guys. So as you can see, there's a chronic inflammatory infiltrate and muscle degeneration. Over here, you can see how there is a phagocytosis of a muscle fiber with numerous macrophages. So just memorize the picture in case they brought it beside the scenario. It's easier to answer this way. Now, this picture is the beginning of the disease of polymyositis. If you remember, we just said that we have the inflammation is endomysial or intravesicular. So it's not. So it starts endomysial or around the fascicles, right? So it's not inside. In this picture, the inflammation is very severe or like very late. That's why you can see it this way. But here, you can see that the inflammatory cells are only in the endomysium. In dermatomyositis, it is the exact same as polymyositis. We have symmetrical proximal muscle weakness. However, here we have cutaneous manifestations or manifestations on the skin. The antibodies that are positive here are anti-MI2 and anti-Jo again. So anti-Jo, same as polymyositis. Adding to that is anti-MI2. Now, what's very important about dermatomyositis is its association with malignancy. So usually, dermatomyositis patients are going to have malignancy in a chance of 20 to 25%, especially ovarian cancer. And this is very important because it's very frequently assessed. So please memorize it. Dermatomyositis, we have proximal muscle weakness, cutaneous manifestations, and finally, a high association with malignancy. Now, this disease, it involves CD4 positive T cells, not CD8 positive. So CD4 positive T cells in the perivesicular and the perimysial region instead of the intravesicular and the endomysial region compared to the polymyositis. So what are the skin manifestations that show in this disease? We have, first of all, Gottron's sign. So Gottron's sign, as you can see here, it causes symmetric erythematous eruptions over the knuckles. This sign is called the heliotrope rash. It's reddish eruption on the upper eyelid. Here we have Scholl sign or erythema on the back of the patient. And finally, the V sign or erythema of the upper chest and neck of the patient. It's important to memorize the names of the signs and how they look. So here is a picture. As you can see, we have pronounced interstitial and perivascular lymphocytes. So it's not here intravesicular or it's not around the fascicles or endomysial. It is perivesicular. So it's around the whole fascicle, right? Okay. Now, diagnostic criteria. So just understand the name of the criteria. We have Bohan and Peter criteria. So Bohan and Peter criteria for the diagnosis of polymyositis and dermatomyositis. And we just talked about this. You can read them. So yeah, for the diagnosis, we're going to talk about that in a bit. We need to have increase in serum skeletal muscle enzymes. So you have to have an increase in skeletal muscle enzymes, which are the creatine kinase and the LDH. Now, in the inclusion body myositis, or the third type of myositis, we don't have symmetrical proximal weakness. Instead, we have asymmetrical proximal and distal weakness. So again, inclusion body myositis, asymmetrical proximal and distal weakness. This is the only thing I want you to memorize for this disease, and that this disease is characterized for the rimmed vacuoles, the hypertrophied myofibers, and the protein inclusions. So mainly the rimmed vacuoles. So rimmed vacuoles, hypertrophied myofibers, and protein inclusions. Those show inclusion body myositis. And this is the picture. As you can see here, we have the rimmed vacuoles inside the muscles. So diagnostic criteria, the labs, you're going to have increased muscle enzymes, mainly CK, aldolase, and LDH, as I said. Inflammatory markers, طبعا, ESR and CRP are going to be high. Those are active phase reactants. Antibodies, ANA, always positive. Anti-Jo1 for polymyositis and anti-MI2 for dermatomyositis. And finally, we can do biopsy. So this is a table I did for you guys just to compare each. One more thing I did not mention is that the prevalence of polymyositis and dermatomyositis is more common in females than in males. However, inclusion body myositis has it more in males than in females. And the creatine kinase level in polymyositis and dermatomyositis will be very high. However, in inclusion body myositis is going to be mild to normal. How do we manage these patients? We just give them corticosteroids. This is very important. Prednisone, 1 milligram per kilogram per day. I think we were asked the exact dosage, like the exact same line over here. So prednisone, 1 milligram per kilogram per day. This is the treatment of choice for myopathies or myositis. Instead of the corticosteroids, we can give immunosuppressants, IV immunoglobulin. This is short-term treatment for steroid-resistant cases, or plasmapheresis, where we just wash out the autoantibodies. We can also give steroid-sparing therapy, including these drugs. It's a long list, صراحة. You can just go through them. Cyclophosphamide and methotrexate are important, and rituximab as well. طيب, now we have a case of drug-induced myositis. So we do not have any autoantibodies or whatever. It's drug-induced. And the most important drugs you need to memorize are the statins, colchicine, steroids, and chloroquinone. Chloroquinone is very important. So chloroquinone, steroids, colchicine, and statins, those induce myositis. Metabolic myopathies, we have the POMS disease and McArdle's disease. We're only going to talk about the POMS disease. It was mentioned twice, once in your genetic lecture and once in your clinical lecture. So what is POMS disease? It is a glycogen storage disease type 2 with acid maltase deficiency. So what happens in POMS disease, we have acid maltase deficiency. So it's considered a glycogen storage disease. It's an autosomal recessive disorder. It's characterized with hypotonia, cardiomegaly, and moderate hepatomegaly. Guys, whenever you hear cardiomegaly in this block, cardiomegaly, hypotonia, على طول, it's POMS disease. So how do we diagnose? We measure the acid maltase deficiency, or we measure the acid maltase enzyme or the alpha glucosidase enzyme. Okay, so we have two names of this enzyme, the alpha glucosidase and the acid maltase. This is the characteristic picture of POMS disease. So please memorize the picture, POMS disease. And these two pictures as well, POMS disease. As you can see here, the cardiomegaly is very prominent. Okay, third, we have the neuromuscular junction disease or myasthenia gravis. Back to myasthenia gravis. Again, myasthenia gravis is an autoimmune disease with characteristic pattern of progressively reduced muscle strength with repeated use. So the reduced strength again happens with repeated use. It is bimodal peak of incidence. This disease is considered a type 2 hypersensitivity, and why is that? It's because the autoantibodies bind the acetylcholine receptors on the skeletal muscles. So when the autoantibodies bind the surface antigen of another cell, this is called a type 2 hypersensitivity. So it involves autoantibodies binding the postsynaptic acetylcholine receptors in the neuromuscular junction. So here are where the receptors should be. We have classifications. We have acquired or autoimmune myasthenia gravis. It could happen because of the passive of transfer of maternal anti-acetylcholine receptors. It could be drug-induced, mainly due to D-penicillamine, and it could happen in congenital myasthenic syndromes. Now, these slides are very important. والله I tried to أقلل الكلام على قد ما بقدر, but these are very important. You need to memorize them. So we have three major abnormalities and we have three pathologies. Okay, so three abnormalities, which are, we're going to have decreased number of acetylcholine receptors in the postsynaptic terminal. So decreased acetylcholine receptors, we're going to have a shortening of the synaptic folds, as you can see over here, and we're going to have widening of the synaptic cleft. As you can see here, the synaptic clefts are widened. So again, reduced acetylcholine receptors, shortened synaptic folds, and widening of synaptic clefts. Those can come as an ACQ, you guys. And why do these changes happen? Because of the antibody. So first of all, what happens is that the antibody is going to block the binding site of the acetylcholine receptors. They're going to cross-link and degrade the acetylcholine receptors, and by complement-mediated destruction of the junctional folds. So again, first the antibody blocks the acetylcholine receptors, and then we have antibodies that are degrading the acetylcholine receptors, and also these receptors are going to be degraded by complement. Now, not all myasthenia gravis have these antibodies or the postsynaptic acetylcholine receptor antibodies. Some cases of myasthenia gravis are called seronegative myasthenia gravis cases. And what is meant by those? So seronegative myasthenia gravis is basically a case of myasthenia gravis that do not have those anti-acetylcholine receptors antibodies, so they're called seronegative. Instead, those cases, they have anti-MuSK. What is MuSK? MuSK is basically a protein that anchors the acetylcholine receptors at the postsynaptic membrane. So if I have an antibody against the MuSK, we won't have anchoring of the acetylcholine receptor, and we're going to have decrease again of these receptors, causing a very similar presentation to the normal myasthenia gravis. Now, an important thing to understand is that myasthenia gravis is usually associated with thymoma. And what is the relation over here? They found out that the myoid cells or the muscle cells are found in the thymus and they express acetylcholine receptors. And this is where the body produces autoantibodies against the acetylcholine receptors because of this presentation of the myoid cells. So they found out, In cases of myasthenia gravis, where the patient has a thymoma, removing the thymoma is shown to improve the case of myasthenia gravis. So, what is one treatment that they're recently doing for treating myasthenia gravis is that they remove the thymus. How do we diagnose? It's important to understand that the diagnosis is done by serum antibodies against the acetylcholine receptors. طبعا except in the seronegative myasthenia gravis where we do anti-MuSK antibodies instead of the normal antibody. And we have some clinical tests that we can do. We have the hydrophonium ice pack test. So in hydrophonium, what is hydrophonium? Okay, so hydrophonium test or the insulin test, it is a short-acting acetylcholinesterase inhibitor. So the hydrophonium is going to inhibit acetylcholinesterase. So we're going to have increased acetylcholine at the motor end plate. So this is going to show improvement in the muscle strength. So if I did the hydrophonium test to the patient, I found that على طول there is an increase in the muscle strength. This is positive for myasthenia gravis. Also, the ice pack test, again, you put an ice pack on the area, for example, on the eye where there is weakness. And because the ice pack, again, is going to increase the acetylcholine in that area for some reason, we're going to have, so you're going to diagnose myasthenia gravis. How do we treat? Mainly, the treatment is by acetylcholinesterase inhibitors. This is the most common treatment. You can give corticosteroids, immunosuppressants, plasmapheresis, where you wash out the antibodies. And nowadays, we do thymectomy to reduce the number of acetylcholine antibodies. Okay, acetylcholine receptor antibodies, sorry. It's not acetylcholine antibody, acetylcholine receptor antibodies. Now, there is a case of myasthenia crisis. What happens here is that we have an exacerbation of the myasthenia leading to paralysis of respiratory muscles. That's why it's very urgent. This usually occurs by infections or inadequate treatment. Those patients should be taken to the ICU so that their respiratory muscles do not fail and they should be treated fast enough. So untreated myasthenia gravis has a 10-year mortality of 20 to 30%. However, with modern treatment, patients with myasthenia gravis are just living normally. And finally, a checkpoint. Let's assess ourselves. So, a 42-year-old woman has been diagnosed with dermatomyositis, presenting with heliotrope rash and Gottschall's papules. Laboratory were performed to assess the disease activity, which finding is going to be high. So, as I said, muscle enzymes should be elevated. Okay, you guys, so now we're going to be talking about the genetics of muscle disorders and muscular dystrophies. So, what are important symptoms of disease of muscle? First of all, we have the hypotonia or the muscle weakness, spasticity, muscle rigidity, loss of muscle control, myalgia or muscular pain, and finally myoclonus, involuntary muscle jerks. So, if I ever see these signs in a patient, I would think diseases of muscle. Now, hypotonia, as we said, we have proximal muscle weakness, and there are signs at the baby's birth that show that this patient has hypotonia. So, first of all, the inverted U shape. So, if you hold the baby in this way, you're going to see because of the decreased muscle strength, they're going to appear an inverted U. And also, we have the scarf sign, which is basically you pull the baby's hand to the other side. If their elbow passes their mouth, this shows hypotonia. A positive scarf sign, again showing hypotonia or floppy infants. And then we have this sign called Gower's sign. So what is Gower's sign? A normal person, when they stand up, they can just stand up from يعني على طول, they just do stand up, right? So in these patients, they need to crawl up until they stand. So they crawl their way backward and then against their body until they're able to stand. This shows proximal muscle weakness. Now, hypotonia is of two types. We have the central hypotonia due to an upper motor neuron lesion or the peripheral hypotonia due to a lower motor neuron lesion. So, what is the difference between these two? In central hypotonia, where there's an upper motor neuron lesion, the hypotonia is going to be with brisk reflexes or very hard or rigid reflexes. So, hypotonia, but the strength is relatively preserved and the reflexes are still found. What can cause central hypotonia? Most importantly is Down syndrome. So Down syndrome, Prader-Willi, and Pato syndrome, they're very important to memorize, you guys. Please do know that Down syndrome Down syndrome, Prader-Willi, and Pato syndrome can cause central hypotonia. Peripheral hypotonia, as we said, lower motor neuron lesion. Here we have hypotonia plus weakness plus absent reflexes. There are no reflexes, no normal tendon reflexes. So this is peripheral hypotonia. The causes are uh, whatever we're going to talk about today. They're basically peripheral hypotonia. So what is more common? Central hypotonia nowadays is more common and it presents in Down syndrome. Now, sometimes I see a patient with hypotonia. How do I know if this case is severe and I need to find a treatment or if it's a mild disease? So we have some alarming signs of physical examination that can tell us what disease this patient is having. So hypotonia plus hepatosplenomegaly alone usually means a lysosomal storage disease. An example is Gaucher disease. You did not have the Gaucher disease in your slide. What the doctor only mentioned that it's hypotonia, like whenever you have hypotonia plus hepatosplenomegaly, but this is lysosomal storage disease. On the other hand, when we have hypotonia plus cardiomegaly, if you guys remember, this is POMS disease or metabolic glycogen storage disease. Third, when we have renal cysts, so when you have hypotonia, renal cysts, high forehead, and wide fontanelles, this is Zellweger's syndrome. Finally, if I saw a patient with hypotonia and when I examined the mother also showed weakness, but this is most likely an inherited disorder or a disorder where the autoantibodies can be passed from the mother to child, meaning either congenital myotonic dystrophy, we're going to talk about this, or myasthenia gravis. Now, finally, dystrophinopathies. Dystrophinopathies are a group of muscle diseases caused by mutation in the dystrophin protein. If you guys remember, dystrophin protein located under the sarcolemma, it's going to take the force from the contractile system and pass it to the extracellular matrix. So if this protein is mutated or mutated, so we're going to have the dystrophinopathies. Now, this protein is mainly found on the dystrophin gene on the X chromosome. For this tells us that dystrophinopathies are mainly or are all X-linked recessive. So mainly boys are affected. So they're X-linked disorders. They include 3 diseases, sometimes 2. So not all people consider the congenital muscular dystrophy as dystrophinopathy. We're going to talk about this. So what are they? We have Duchenne muscular disease, Becker's muscular dystrophy, and congenital muscular dystrophy. How do we investigate? We investigate by muscle enzymes. Again, we have CK or creatine kinase enzyme. We do muscle biopsy and genetic testing to check for the protein dystrophin. And finally, EMG to decrease the amplitude. وطبعا Gower's sign, as you can see over here. So the patient is crawling its way up until they are able to stand up normally. Now let's start with Duchenne muscular dystrophy. So all these diseases, they're diseases of proximal muscle weakness. So you have proximal muscle weakness that presents at the age of 5 years old. So you have an early presentation. On physical exam, we're going to see that the patient has lumbar lordosis. I think there's a mistake here, but okay. So mainly they have calf pseudohypertrophy. Okay, so calf pseudohypertrophy is very characteristic for Duchenne muscular dystrophy, as well as neck flexor weakness and Gower's sign. For diagnosis, we said we're going to do CK, and it's going to be very highly elevated. On muscle biopsy, we have absent dystrophin. Now, these patients, because of the severity of this disease, they usually die in their 20s because of respiratory or cardiac failure. This is very important to understand. So why do these patients most likely die? Because of the respiratory or cardiac failure. So when I have a patient of this disease, what is my main goal? I need to manage his respiratory and cardiac symptoms in order to delay their failure as much as possible. Becker's muscular dystrophy is the same as Duchenne, however, it has a slower course. And because it's a slower course, they usually present after 5 years old, so from 5 to 15 years old. Those patients can live to their 40s and 50s, unlike Duchenne's disease. Now, again, the CK will be elevated, but not as much as in Duchenne. And in muscle biopsy, we have decreased dystrophin, not absent dystrophin. So management, again, we do respiratory care, dysphagia care, and musculoskeletal care. Finally, we have the congenital muscular dystrophy, which is the third type of dystrophinopathy. Now, why do not all people consider this a dystrophinopathy? It's basically the protein that are defected are not dystrophins. They are laminin A2, collagen 6, and POMT1. طيب, so the protein that is defected is not dystrophin. However, when these proteins over here are affected, they can cause the defect of dystrophin, right? So we have these proteins are defected And these proteins are not found on the X chromosome, like we said in the other dystrophinopathies. So this disease is autosomal recessive. So that's why not all people consider it under the dystrophinopathies because the proteins are different and because it's autosomal recessive, not X-linked. Hello. So this is a very harsh disease. It presents at birth with severe hypotonia. Again, this is the inverted U sign, and here there is no cardiac involvement, unlike Becker's and Duchenne. We have other types of dystrophies. I don't think they're very important. You just need to see their the muscle distribution. بصراحة, I don't think the doctor is going to ask about this. I've just put it here for the sake of completion. So limb girdle or girdle dystrophy. It's an autosomal recessive disorder. It's usually common and benign. So initially we have the pelvic and shoulder muscle involvement, and then we have the pelvic and shoulder muscle involvement from proximal to distal. So this is a comparison. Duchenne and Becker are usually put together. As you can see, they start from 2 to 6 years. Becker is usually later on. This is their muscle distribution, and again, the genetic linkage is dystrophin protein disorder. Limb-girdle, it happens in the late childhood. As we said, it's a benign, not benign, but like, yeah, a more benign disease. So life expectancy is higher. The genetic linkage here, as you can see, many other proteins that are defected, and it is autosomal recessive. This picture is from your doctor's slide. The doctor did not mention anything about this disease. Just read about it from this slide. I don't think he'll ask you any about them. Again, so this shows the different distribution of muscle involvement in different diseases. Here we have the facioscapulohumeral type. As you can see, we have the face involvement. Here we have the oculopharyngeal type, where we have eye involvement. Okay. Now, other myopathy, we have the nemaline myopathy. All you need to know about this disease is that it's an autosomal recessive disorder, and that those patients, they cannot breathe, so they need to be put on nasogastric tube. What's very important is the rod-like accumulations. So nemaline myopathy, so showing proximal muscle weakness, patient cannot breathe, so they put a nasogastric tube. On biopsy, they saw rod-like accumulations. Think nemaline myopathy, and these are the pictures for nemaline myopathy. بصراحة, I don't know what this picture has to do with the disease. I think she's just showing you that the patient is the only one affected because it's an autosomal recessive disorder. Now, spinal muscular atrophy, or SMA. This disease is very important, and it's very important to note that this disease is not a muscular disease of origin. This disease is an autosomal recessive disorder that is caused by degeneration of the anterior horn cells in the spinal cord. So basically, what these are, they are like neural cells. Okay, so their degeneration of the spinal cord. Memorize the sentence just as it is. I think it did not take neuro yet. صح, second years they did not take neuro yet. I forgot يا أخي والله my ما علينا ما علينا. Okay, so degeneration of anterior horn cells in the spinal cord causing denervation and muscle weakness. So we have progressive proximal muscle weakness and paralysis. So after the degeneration of the spinal cord happens, because of the denervation, we're going to have muscle weakness. What's important about this disease is we have a mutation in the SMN1 gene. So SMN1 gene is for the SMA disease. Here, the muscle enzymes are normal. And why is that? Because the inflammation is not in the muscle itself. Again, it's in the spinal cord. Now, the doctor really emphasized on how this is becoming very popular in case A, and that premarital screening is done for it. Here we have the classification criteria for the spinal muscular atrophy. Again, just for the sake of completion, I don't think she's going to ask you something this advanced. Finally, we have the congenital myotonic dystrophy. What is myotonia? Myotonia is a slow relaxation of muscles after voluntary contraction or electrical stimulation. So this disease, it's an autosomal dominant disorder, again characterized by hypotonia at birth. Now, what's important about this disease is that when you take history from the mother, she's going to tell you that she had reduced fetal movements, and there will be a clear history of polyhydramnios. Often progresses to respiratory insufficiency and early death. Intellectual disability is common. So whenever I am thinking about this disease, I need to assess the mom. I go and check the mother's grip, and most likely I'll find that the mother's grip is weak. So this shows us the diagnosis of congenital myotonic dystrophy. So again, it's an autosomal dominant disorder that presents as hypotonia at birth. There will be a history of reduced fetal movements and polyhydramnios. The mother's grip is going to be affected. So for diagnosis, what we do is that we check an expansion of the GTC. So it has a trinucleotide repeat. I know the diseases become confusing the more we take more diseases, but with practice questions, you guys inshallah are going to master them. Now, I used to confuse a lot between congenital muscular dystrophy and congenital myotonic dystrophy because the names are very similar, but they're very different in like presentation. Congenital muscular dystrophy, if you guys remember, we put this as a dystrophinopathy. We said Duchenne, Becker, and then congenital muscular dystrophy. Now, okay, let's keep this aside straight. Then we have the congenital myotonic dystrophy, which we just talked about right now. We said in congenital myotonic dystrophy, we're going to have maternal symptoms. So the mother is going to have a problem. She's going to have myotonia, okay? So, or a problem in her muscles. Respiratory distress is present in congenital myotonic dystrophy. Pregnancy sign, we're going to have polyhydramnios and reduced fetal movement in congenital myotonic dystrophy. In genetics, congenital muscular dystrophy is autosomal. Congenital myotonic dystrophy is, muscular dystrophy is autosomal recessive. Congenital myotonic dystrophy is autosomal dominant. Okay, so these features, just memorize these features whenever you see them, maternal symptoms, polyhydramnios على طول think congenital myotonic dystrophy myotonic dystrophy not muscular dystrophy myotonic dystrophy. Okay, and this is our checkpoint. Let's get a case. So this case is from your doctor's slide. A 5-year-old male is brought to your office because his mother noted that he has difficulty with activities that other children in his kindergarten class can do well. He sat up at 10 months and began to walk at 18 months. So these are late signs. Usually babies sit at 6 months maybe and they walk at 12. So this is considered late. Now he cannot stand or hop on one foot. He's behind in learning the alphabet, colors, and number. So guys, I just want to give you a tip. If you were very confused between Becker's and Duchenne, just think about severity. Like, is it severe? Is the patient intellectually disabled? So here he's behind in learning the alphabet or colors and number. So we're most likely thinking Duchenne, right? Not Becker, because Duchenne is more severe than Becker. حتى the presentation 5-year-old is more of Duchenne's disease. Now for musculoskeletal, we have mild lordosis and mildly enlarged calves. Neuro, we have mild diffused hypotonia. So what do you guys think? This is Duchenne muscular dystrophy. Which of the following is true about its inheritance? It is X-linked recessive. The other case, we have a newborn male is delivered at 38 weeks after a pregnancy complicated by polyhydramnios, reduced fetal movement, very characteristic of what? Congenital myotonic dystrophy. So at birth, the baby is floppy, and you notice a weakened grip of the mother. So this is congenital myotonic dystrophy. Now, fibromyalgia. Okay, so this disease, we actually had an ACQ about it. Oh, it was kind of a shock because no one expected an ACQ about a disease that no one understands anything about, right? So, but I think from what I remember, we did good in it. It was just kind of a shock. So, what is fibromyalgia? It is a condition of chronic pain diagnosed by pain in at least 4 or 5 body regions for at least 3 months. So, 3 months is very important. And chronic pain diagnosed by pain in at least 4 or 5 body regions. It's more common in females. Now, the pathophysiology is not fully understood, but it is predicted to be hypersensitization of the central nervous system. So the central nervous system becomes more sensitive to pain, so it manifests as fibromyalgia. And what can trigger the fibromyalgia? Basically anything. Infection, trauma, emotional stress. We got a question on like list, I think 8 things that can trigger fibromyalgia. ويعني حرفيا this lecture عبارة عن اهبد ولا تبالي والله العظيم I remember we were just writing anything that comes to our mind الحمد لله it passed so اهبد ولا تبالي. Okay, physical examination reveals tenderness in multiple soft tissue locations. Laboratory testing is normal. This is very important because there is no muscle disease. There is no issue with the patients themselves. The issue is in the hypersensitization of the CNS. Okay, so now for history, we're going to have widespread multi-site pain present for at least 3 months. There will be fatigue, sleep disturbances. On physical exam, we're going to have widespread or multi-site tenderness. Laboratory testing, again, as we said, they're going to be normal, especially the acute phase reactants. So for diagnosis, we have diagnosis mainly occurs clinically after exclusion of other diseases. Now, this is a new thing the doctor has added in your slide, the cytokine array-based blood test. So what this is that patients with high fibromyalgia demonstrate higher cytokine production. So we basically measure the cytokine in the body. If it was high, for this suggests fibromyalgia, again, not diagnostic, but it's a kind of test they do, and they do not usually do it because it's very expensive. It does not confirm the disease. It's just good to know. Okay. So this is the criteria, American College of Rheumatology Fibromyalgia Diagnostic Criteria. You can read it. We have the widespread pain index, which is basically an index that is that locates the pain that the patient has, and you give a point or two for each. Okay, so what are some differential diagnoses for fibromyalgia? Inflammatory arthropathy, spondyloarthritis, connective tissue disorders. So again, a lot of diseases can be differentials. فas I said اهبد ولا تبالوا. Okay. What is this? Okay, this is again another kind of screening tool for fibromyalgia called FIRST, Fibromyalgia Rapid Screening Test. So you see the patient having these or complaining of these things. Again, it's good to know. Most importantly, guys, I want you to understand that fibromyalgia is diagnosed clinically after exclusion of other conditions. Again, clinically after exclusion of other conditions. For therapy, initially you confirm the diagnosis and you educate the patient that there is no um, nothing specific to treat. However, we'll try to نحسن symptoms. And how we do that, we usually give low dose tricyclic antidepressants. So low dose tricyclic antidepressants for patients with fibromyalgia. وطبعا if patients do not respond, we give them other multidisciplinary treatments. So first we go with the pharmacological treatments, and then we go for physical therapy, cognitive behavioral therapy, depending on the severity of those patients. These are the medications for fibromyalgia. Most importantly, you need to understand the amitriptyline or the tricyclic antidepressants. Okay, we're done with the muscles. Let's go to connective tissue diseases. So in this lecture, the doctor did not explain the whole disease. He literally just told you, this disease has those extra MSK manifestations or systemic manifestations. So what I did is that when the disease, if I saw I saw that there are some diseases that are explained in other lectures. So I'm just going to we're going to solve a question on each disease, and then we're going to discuss the systemic manifestations of each. So a 52-year-old woman has chronic symmetric MCP and PIP arthritis, prolonged morning stiffness, and positive RF and anti-CCP. So this shows what rheumatoid arthritis, right? Now, what are the systemic manifestations? She also has subcutaneous nodules, dry eyes, episcleritis, interstitial lung disease, and anemia of chronic disease. Which condition best explains all of these findings? Again, as we said, rheumatoid arthritis. Rheumatoid arthritis is associated with extra-articular manifestations. And if you remember, what was the lab that is mostly associated with this? It is the rheumatoid factor. So high titers of rheumatoid factor is going to indicate extra-articular manifestations. So what are the most important manifestations? And the episcleritis, interstitial lung disease, the nodules. Nodules are the most common. I'm not going to explain the disease in details. I'm pretty sure my colleague Zahra did a very good job on this, so you can watch the first part of the MSI crash course. Now, a 28-year-old woman presents with malar rash, photosensitivity, painless oral ulcers, non-erosive symmetric arthritis, Raynaud's phenomenon, serositis, and proteinuria. Labs showed ANA, anti-double-stranded DNA, and low complement. What is the most likely diagnosis? So this is SLE, malar rash, SLE. As you can see here, this is the malar rash, this is the oral ulcers. So SLE. So in SLE, what's most important, as I said before, ANA has to be positive. I cannot diagnose SLE with ANA. What are other antibodies that can be positive? We have the anti-double-stranded DNA, anti-Smith, and low complement levels. We diagnose SLE by a criterion called the entry criterion. You don't need to memorize what is it about. Just know that entry criterion is used for SLE. Same thing if you guys remember for dermatomyositis, polymyositis. What was the criteria we used? It was Bohan and something. Just memorize the name of the criteria. Now, what are the most important manifestations of SLE? We have the butterfly rash, the vasculitis, the arthritis. So it's good to correlate these to the SLE. Like SLE was explained thoroughly in your immuno lecture. So let's هيك نروح شوي على الاميونولوجي. And SLE is basically a type 3 hypersensitivity. If you guys remember, myasthenia gravis was type 2 hypersensitivity. SLE is type 3 hypersensitivity where we have antibodies reacting to antigens. Okay? What are the most frequent autoantibodies found in patients with SLE? As I said, we have ANA, we have anti-double-stranded DNA, and we have antihistones. Your immune lecture really focused on antihistones. So, just memorize SLE antihistones, SLE antihistones, and it's a type 3 hypersensitivity reaction. طيب, why do autoimmune diseases happen in first place? So what happens? What is normal in the body and what is abnormal? And why do we have unresolved autoimmune diseases? So this is due to two things. We have antigen sequestration and epitope spreading. So what is antigen sequestration? Basically, sequestering means hiding. So antigen hiding. This is what usually happens in our body. Our cells are closed structures that have antigens inside. Hello, those antigens should not leave the cell, should not be exposed outside the cell. If we have the loss of antigen sequestration or antigen hiding, we are going to have an autoimmune disease. Same as epitope spreading. Again, after the antigen leaves the cell and becomes exposed, some cells are going to come and take this antigen and it's going to spread it all over the body, causing unresolved autoimmune disease. So here, this is what I just said in antigen sequestration. Circulating B cell binds self-antigens released from the injured cell. So we have an injury producing antigens. B cell is going to bind to these, it's going to take it, and it's going to present it to other autoantibodies that is going to cause further immune reactions. So what is the antigen that is shown in SLE? What is the antigen that is no more hidden in SLE? It is the nucleosome. So very important. The target antigen for SLE is nucleosome. So we have nucleosome expression outside the cell causing autoantibody reaction. And what is the antibody again? It is antihistone. So antihistone reacts to nucleosome. Epitope spreading, again, as I said, the B cell is going to take this epitope or the nucleosome and it's going to express it to other B cells and T cells, causing a further prolonged autoimmune reaction. So B cell endocytoses the whole nucleosome and present H1, H2, H3 epitopes, whatever, to other TH cells, stimulating other B cells to make more antibodies. That's why it's unresolved autoimmune response. Now, we're going to talk about scleroderma or about systemic sclerosis. I think you guys took this in your PBL and you're going to be having a PBL session or a PAL session about scleroderma. But just for the sake of completion, I'm going to explain it a bit. Scleroderma is a chronic autoimmune connective tissue disorder that is characterized by excess collagen deposition leading to skin thickening. So you have excess collagen deposition leading to skin thickening and fibrosis of internal organs, and it's also associated with a small vessel vasculopathy like Raynaud's phenomenon. Okay, and those are the manifestations of systemic sclerosis. We have heart involvement, a renal crisis. So those are the systemic manifestations. So here, this is a special sign for scleroderma called sclerodactyly. So because of the excess collagen deposition over here, we are going to see the hand very stiff and it's unable to open and close properly. And this is Raynaud's phenomenon where we have a change in color of the skin due to stress or cold or whatever. Now, scleroderma is divided into localized scleroderma that only affects the skin and systemic scleroderma where we have other organs in the body also affected. Now, the systemic scleroderma is further divided into four types. We have the limited cutaneous, where the skin manifestations are very severe with only limited organ organs that are affected, or we have the diffuse cutaneous, where a lot of organs are affected, sign scleroderma, where the skin is not affected, only organs are affected, and we have the overlap syndrome. So localized scleroderma, as you can see, these are signs of localized scleroderma. We have the plaque or the circumscribed morphe. Plaque or circumscribed morphe. And here we have the enqueue or the sword sign. I don't know what this is called صراحة in your يعني the doctor usually writes it in English. I don't know why he wrote it in French this time. بس يعني it's a sword sign, as you can see over here. And this is the plaque or the circumscribed morphe. As we said, systemic scleroderma, it includes limited cutaneous, diffuse cutaneous, sign scleroderma, and overlap syndrome. In limited cutaneous, we have skin thickening restricted to hands, forearm, face. This is the disease that is related to crest syndrome. So as you can see here, calcinosis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, telangiectasis. The antibody is anti-centromere. I don't want to explain this thoroughly. I'm pretty sure, as I said, we're going to have a PAL session on this. So you can just come back to the slides if you ever wanted, if you ever had anything missing, yani. So this is the calcinosis, as you can see on pictures. And diffuse cutaneous, we have widespread skin involvement plus organ involvement, including the interstitial lung disease, renal crisis, myocardial fibrosis, and GI dysmotility. The antibody is anti-SCL70. Sign, scleroderma. Sign means without. So this is systemic scleroderma or systemic sclerosis without the skin involvement. Autoantibodies are ANA, anti-centromere, and other antibodies. And finally, we have the overlap syndrome, where we have other autoimmune disease manifestations. So you can see polymyositis, SLE, RA, Sjogren syndrome. Okay, and the antibody is anti-PM or SCL. Okay, so here we have one more question. A 27-year-old man presents with chronic low back pain for 1 year. He has recurrent acute anterior uveitis, reduced chest expansion, and mild aortic regurgitation murmur. ESR or CRP are elevated. HLA-B27 is positive. So what is the most likely diagnosis? This is ankylosing spondylitis. So ankylosing spondylitis is one of the articular diseases that have a lot of systemic manifestations. Most importantly, it's important to understand the acute anterior uveitis, the aortic insufficiency, kidney disease. And what is very important is that those diseases are HLA-B27 positive. If you guys remember, we said that this is a protein that is present on the top of white blood cells. Now, what are other diseases that have MSK manifestations? So here we have the other way around. It's a systemic disease that manifests as MSK. First of all, we have the inflammatory bowel disease, where we have inflammation of the bowel. They can manifest as type 1 arthritis, type 2 arthritis, and axial arthritis. Second, we have the sickle cell disease. Sickle cell disease can present as osteomyelitis or septic arthritis, or sometimes ischemia and infarction. Diabetes mellitus can manifest as frozen shoulder, carpal tunnel syndrome, and a contracture on the palmar surface of the hand. Sarcoidosis can present as osteoporosis, arthromalagia, and myositis. We were not asked about any of these. Again, this is just for the sake of completion, and they're not very hard, so you can just read about them. Finally, I think this is our last checkpoint. We're going to have a bit about immuno. Yes, so a couple more slides about immuno, and inshallah we'll be done. So I think you guys know about this. We have two types of lymphoid organs. We have the primary lymphoid organs and the secondary lymphoid organs. Primary lymphoid organs include the thymus and the bone marrow. Secondary include the spleen, lymph nodes, and the liver in the fetal life. Guys, please memorize this. We got a question, ويعني haram if you make a mistake in this question. So primary thymus or bone marrow, secondary spleen, lymph nodes, and the liver in fetus life. The function of primary is the regeneration and the maturation of the precursor cells. The function of the secondary is basically concentration of antigens for presentation by antigen presenting cells. Now, there is this concept called the tolerance. What is tolerance? Tolerance is the ability of the immune system to avoid attacking the body's own tissue. If you guys remember, we talked about the sequestration, where the body hides the antigen. This is, again, a kind of tolerance technique that the body uses. Type for tolerance, we have two types: the central tolerance and the peripheral tolerance. Central tolerance is where we block the immune reactivity to self antigens and beneficial antigens, and this is done by something called the anergy. What is anergy? It's basically when we have lack of co-stimulation, so we are going to prevent the autoimmune reaction. In peripheral tolerance, we remove the potentially autoreactive. So in peripheral, we remove whatever could cause autoreaction. In central, we block this activity by energy. So again, as you can see here, we have the lack of the CD83, CD86 binding, so lack of co-stimulation. And that's it, you guys. We're done with our session. Let's go over a couple of practice questions so that we can make sure you guys mastered the concepts. So, question one: a 48-year-old previously healthy woman comes due to progressive worsening muscle weakness for the past 2 months. The patient has difficulty with activities such as climbing stairs, getting up from chairs, and placing dishes in overhead cabinets. She also reports a 4.5 kg unintentional weight loss. Physical examination shows weakness of the shoulder and hip girdle muscles. Other examination findings are found in the image below. So as you can see here, we have some cutaneous manifestations. If you guys remember, here we have the signs that we talked about. So what is this disease? This is dermatomyositis. Type, which of the following is associated with dermatomyositis? وعندنا 4.5 kg unintentional weight loss. Exactly, it is ovarian adenocarcinoma. It's very important to associate malignancy with ovarian adenocarcinoma, you guys. Next question. A 4-year-old boy is brought to the emergency department for right ankle injury. Okay. The mother said that he has fallen multiple times in the last year. He has reached most of his developmental milestones but did not walk until the age of 17 months. He is the only child that was adopted at age 1. Okay. He has marked enlargement of both calves. When standing up from lying position, the patient crawls onto his knees and slowly walks himself up with his hands. Which of the following is the most likely underlying mechanism of this patient's condition? So we are thinking Duchenne's disease, right? So what is the mechanism? It is the absence of dystrophin protein. A 47-year-old woman comes to the physician because of body aches for the past 9 months. She also has stiffness of the shoulders, knees, that is worse in the morning. A complete blood count and erythrocyte sedimentation rate are within the reference ranges. Which of the following is the most likely diagnosis? So body aches, 9 months, normal labs. So this is fibromyalgia. A 25-year-old woman complains of weakness and easy fatigability, which is most pronounced in the late afternoon. So after she does exercises or after she does the effort, physical examination reveals ptosis and diplopia. Laboratory studies would most likely demonstrate serum autoantibodies directed against what? It is acetylcholine receptor. Excellent. And what is the therapeutic? What is a new treatment that they are using for patients with myasthenia gravis? Which of the following may be of therapeutic benefit to the patient? We said thymectomy. Thymectomy. Excellent. Finally, define sequestration. So sequestration is the hiding of host antigens from the immune system. That's correct. In SLE, which autoantibody? So, okay, this question was, this is how it was written, يعني, but I think it's not written the right way. But the question is asking about what is targeted, يعني, what do autoantibodies target initially in SLE? It is the nucleosome. And that's it, you guys. Thank you very much for watching this session. I really hope it did benefit you. Again, as I said, if you have any questions, these are my contact info. I'll be more than happy to help, even if it's something outside this course. And please scan this code to give us some feedback. And yeah, that's it, you guys. Have a nice day and good luck on your exam.